So it is my great pleasure to introduce Dr. Paul Higuero today. Dr. Higuero studied medicine at the Universidad Nacional Autónoma in Honduras. He subsequently completed his residency at Jackson Memorial Hospital, University of Miami, where he was also chief resident. He completed his pulmonary and critical care fellowship at the Medical University of South Carolina in Charleston, where he had a particular interest in ILD and worked with Lynn Schnapp on molecular mechanisms of fibrosis and clinically in the ILD specialty clinic for additional training in the care of these complex patients. We all got to know him in 2017 as that awesome guy from MUSC who's doing nights, and we were very excited in the MICU to have somebody who was doing such an amazing job. And then we were very lucky to recruit him into the ILD program. So since he has been with us, he has made a name for himself in the clinical space as an outstanding ILD doctor who's sought after for second opinions and loved by his patients. And also in the educational space where he is sought after for his teaching, supported by his extensive understanding of the literature and his clear explanatory style. He's been particularly interested in connective tissue disease and has collaborated on papers in scleroderma and post-COVID fibrosis. But what he's going to talk to you today about is particularly exciting. So JP saw that there was a clear need for a specialist in rare forms of cystic lung disease, and he took on that challenge. He's developed a multidisciplinary group that shares in the diagnostic evaluation and management of these patients, and his work has been recognized by designation as a Lamb Foundation clinic, and he's the director of that clinic. He's spoken nationally about cystic lung disease, and he is our go-to person for all things holy. And I am very excited to hear more about the diagnostic approach to cystic lung disease. So welcome.
Thank you for your kind words, Danielle. So this is actually my first grand round since I started at Yale. So when they asked me to give a talk, it's like I've been working on this cystic lung disease program for the past 2 years now. It's like I want to talk about that. I did struggle to decide, do we talk about all cystic lung diseases? Do we talk about LAM in particular? So it's like, oh, this is the first talk. I'm going to talk about all cystic lung diseases and sneak a little bit more LAM than the other one. So we'll go over this. Like I said, I was interested just because I saw that there was a need when we had the clinic, and it really has started to grow from having like a couple of patients to now being a LAM clinic, which gives us national recognition and we get referrals. So let's get started. First, I have nothing to disclose, and here's your code for CME accreditation. So what are we going to talk about? So first, I want to define what a diffuse cystic lung disease is. I want to talk a little bit about the mimics that we're going to see. I want to talk a little bit longer about LAM, although it could be hours of if we just did LAM-focused talks. And then I'm going to outline a diagnostic approach to the patient that presents to the clinic with diffuse cystic lung disease. So let's start with a case. So 35-year-old female, progressive dyspnea, has some mild wheezing for the last 6 months. Her PCP has treated her for asthma. He gave her a bronchodilator, he gave her Advil. She had some symptomatic improvement, but her symptoms have not fully resolved. She has seasonal allergies. She's on omeprazole for reflux. She's also on a oral contraceptive for abdominal recurrent bleeding. Family history of coronary artery disease. She's a never smoker. And teacher, no pets. On physical exam, so vitals, a febrile, normal BP, respiratory rate is fine. She's 96% on room air. The physical exam, well, she's well appearing, clear auscultation, regular rate and rhythm, no edema, no clubbing. The skin doesn't have any evident lesions. There's no fibrofolliculomas, and that's important. We'll know later why. Then we look at PFT. So PFT is just a forced vital capacity in the 80s, FEV1 68%. Non-obstructive ratio, TOC is normal 90%. Her diffusion capacity is mildly reduced. Then we get a CT because, well, she's been treated for asthma, it's not getting better. They get a CT and we see this. So now we're surprised. So what are we gonna do? So my question for you in the audience is, so which of the following will be the next step to try for obtaining a definitive diagnosis? Okay, good. So I'll get into more why. So transform lung biopsy, referral to genetics, BGFD testing, referral to dermatology, all of the above. So first, when I think of diagnostic approach for cystic lung disease, there's a couple of questions that we ask. So is this truly a cyst or a cyst mimic? How many do you have? Can you make a diagnosis based on the radiology pattern? Are there any systemic symptoms that are going to tell me or are going to suggest a specific diagnosis? And then are there any symptoms or evidence that this patient is experiencing physiologic decline that I'm going to blame on the lung cyst? So first, what is a lung cyst? So any round circumscribed space that is surrounded by an epithelial fibrous wall. That's the pathologic definition. So radiology is surrounded parenchymal lucency that is surrounded by normal lung. And it has a variable wall thickness, but usually it's a very thin wall, so less than 2 millimeters. So we group diffuse cystic lung diseases together because they share the cyst, but in reality, they're a very heterogeneous group of disorders in how they behave. They are all considered, like the causes of cystic lung disease are all rare. And how do we define rare? Like it's actually a disease that affects less than 200,000 individuals. The incidence and prevalence, we make all these estimates and there's papers for specific diagnosis, but the reality is we don't know. It's probably underestimated. I'm getting a lot of referrals now for everybody that gets a coronary CTA. You know, we found some losses. What do we do with it? The mechanism of the cyst formation are varied. There's a ball effect, there's ischemic dilation, there's connective tissue degradation. So then they're going to behave very different in their natural history. So what are the cyst mimics? And sometimes it can be tricky. So emphysema. So emphysema is going to be a focal area of lung attenuation and without a visible wall. The thing with emphysema, what I usually look for is that they have a central dot sign. So basically you have lots of parenchyma, but there's a blood vessel between in the lucency, in the middle of the lucency, that tells you emphysema. Honeycombing, so cluster cystic spaces, they're varied in diameter, but they're usually a contiguous row and they're in periphery. Cavities, which cavities usually what differentiates them is they have a thick wall. And then bleb, which blebs are the third spaces that are usually associated, occur in the presence also of emphysema, and they're also a peripheral, have a thin wall. So those are like the cyst mimics. So when I find a cyst on a CT scan, how do I know it's meaningful? So has anybody looked at this? So when they look at the Framingham Heart Study, they looked at everybody that had a CT chest and at least one pulmonary cyst, and they found that 7.6% of patients had at least one cyst. And there was a correlation between older age and lower BMI to having more cysts. So this was interpreted as that you can have some cysts and are usually a sign of lung senescence. So as you get older. So, but multiple cysts, so we're only seeing in about less than 1% of patients, so more than 5 cysts. So there's different cutoffs that have been proposed for what is a normal amount of cysts that I need to do evaluation for diffuse cystic lung disease. So 5 is based on this study. Other groups have proposed 10. So less than 10, they really started talking about like, we're not going to do anything about this, but this needs more validation. But when somebody comes in and has 2 or 3 cysts, definitely we're not doing anything about it. So the classification. So there's different ways of classifying lung cysts. One way is based on mechanisms and the underlying etiology. So neoplastic, that's where we put Lamb, that's where we put Erhard Chester. The malignancies, genetic, so Birdwell-Duvet, which is the most common one, Proteus syndrome, neurofibromatosis, Marfan's, Lloyd-Dietz syndrome. Associated with lymphoproliferative disorder, the most common is LIP, follicular bronchiolitis, amyloid, light chain deposition. Infections, the one we're taught is PJP, post-PJP. Staph can give you pneumatoceles. And you can also see some cysts associated with ILDs, and we talked about this, for example, hypersensitivity pneumonitis or smoking-related DIP, we'll also see some cysts. And other post-traumatic cysts, fire eaters, lung, which is interesting. You have a fire eater as a patient. Hyper-IgE, which is immunodeficiency. It's a rare immunodeficiency. when they think about like this paper by Gupta, by Nishant, who is out of Cincinnati, he tried to just highlight that there's overlapping mechanisms in the disease, like LAM behaves as neoplastic, there's also a genetic component. So that's another way of grouping them. And then we have the mimics, the congenital ones, infections, and others. So which are the most common? So there's this paper out of China, which is really one of the biggest cohorts I've seen. We don't have any published data here in the US of a cohort this size. And this was all their patients collected across 17 years in their rare lung disease clinic. And was more than 1,000 patients. And what they saw was LAM, Burgos-Dubé, Sjogren's, PLCH, and undiagnosed about 20% of patients. And I think this number is only going to go up and up as more people are getting CAT scans for non-pulmonary reasons. So let's start talking about LAM. So LAM is how it's defined, and this has been a matter of debate, but now it's agreed that it's actually a neoplasm. So it's a slowly progressive, low-grade neoplasm that's characterized by the infiltration of the lung parenchyma with this abnormal smooth muscle cell, the prototypical lung cell, that basically grows unchecked and results in the development of a cyst space within the lung. So the prevalence, and I talked about like how the prevalence is underestimated. There was a recent paper out of Europe looking at national cohorts, and they realized that they have a higher prevalence than initially was thought, and now it's estimated to be about 20 cases per million in the US, extrapolated based on that data. So that, for purposes of thinking of like the Connecticut population, that would mean that in this state we have 74 women with LAM somewhere around that number. So this is a brief, like very, very small thing about the pathogenesis. There's much more mechanisms behind this, but how do I think about LAM? So LAM cells arise from an unknown source. There's actually debate about where this metastasizing smooth muscle cell is generated. There is some data to suggest that they actually come from the uterus, and they have mutations in the tuberous sclerosis gene. So it can occur as part of a germline mutation in patients that have tuberous sclerosis complex, or it can be a somatic mutation, and it's just called sporadic LAM. So what is the mechanism? So what is thought is that these cells with the TSC1 or TSC2 mutations secrete BGFD that basically recruits lymphatic endothelial cells, and then the lymphatic endothelial cells help them by matrix degradation and MMPs to invade into the vasculature. And in the vasculature, actually estrogen is helping them survive all these LAM cells surrounded by the lymphatic endothelial cells. So they migrate, and where do they go and deposit? So they deposit in the lung, they deposit in the kidney, and they deposit in the lymph nodes. So BGFD is important, estrogen is important, and this has to do with also the clinical manifestation. So I want to highlight that. So how do patients present? So the most common presentations are going to be just progressive dyspnea or spontaneous pneumothorax. About 30% of patients are going to present with a spontaneous pneumothorax. And that just goes to highlight. You get a spontaneous pneumothorax, you get a CT, you need a CT. And although you think it's evident, it does happen that we get patients that didn't get their CAT scan until their second pneumothorax. It's more frequent in women of childbearing age. It's usually between 30 and 40 when they present. And the wheezing and the fact that they have bronchodilator response can actually make their clinicians diagnose them as asthma, and they carry this asthma diagnosis for a while until they continue to get worse. They can get chylothorax because of the issues with lymphatic infiltration. Other symptoms, chest pain. In the absence of pneumothorax, a lot of women will have complain of chest pain, and this is believed to be like microcyst rupture that is causing them this pain. Chyloptysis, chyluria, hemoptysis after sexual activity have been described, and they think that's just besides the fact that it's an exercise that's gonna like raise pressures within the lung, that it also just goes to show like the damage to the vasculature from the invading LAM cells. non-pulmonary manifestations, so what are the other things that we look for? So renal AMLs. In patients with sporadic LAM, it happens in about 30% of cases. In patients with tuberous sclerosis LAM, it's going to be about 80% of patients. And when in patients with tuberous sclerosis LAM, they get bilateral renal AMLs, multifocal renal AMLs, so it's more common. Now, the lymphatic manifestations, like something in big groups of clusters of lymph nodes that are called lymphangiomas, or chylosfusions, that is actually more common in the sporadic LAM. So you get lymphangiomas, chyloperitoneuum, lymphadenopathy, and uterine lymphangiomatosis. There's a lot of cases of women getting like hysterectomies and then being diagnosed with uterine lymphangiomatosis without other manifestations. So tuberous sclerosis, just a reminder, which is TSC LAM, it's actually an autosomal dominant or cutaneous disorder. And what happens is you have a mutation in the TSC gene, and that leads to overactivation of the mTOR pathway, which is mammalian target of rapamycin. And you start developing benign tumors everywhere. For tuberous sclerosis, most cases are going to present very early in childhood. It's more like within the first year of life. So it's rare that we're going to have, it doesn't happen commonly that we see somebody in the adult clinic without having the diagnosis of TSC done way before. Most of the cases that we're dealing with are like sporadic LAM. And this is just a manifestation, like all the spectrum of clinical manifestations that can be seen in tuberous sclerosis. And so there's actually guidance specific for tuberous sclerosis. And you start screening patients in their 20s with regular CT chest trying to catch when they develop the lung cysts. It's harder to miss because there's multiple like skin manifestations. They can get teeth manifestations, gum manifestations, retinal hematomas, cardiac manifestations. So what does LAM look like? So there's diffuse cysts. It's uniform, so they're round, thin wall. They're mostly sub-centimeter, and there's nothing else abnormal in the parenchyma. So that European respiratory guidelines, it describe what is a characteristic CT, and they said this, but it needs to have more than 10 cysts. While they said it compatible if you have like 3 to 10, that's where like the debate about what is enough for us to look for diffuse cystic lung disease, and that's where we end up in like 5 to 10. So how do I think about LAM? So the patient shows, and either they got like shortness of breath, pneumothorax, and they get a CT of their chest. So first of all, is the CT, does it have characteristic features of LAM? So it's a multiple, diffuse, round, thin wall cyst. So if it doesn't have typical features, then think about something else. Now, if it does the patient have any features to suggest that they have tuberous sclerosis LAM? If they do, then you send it to genetics and it's already diagnosed, but most of the time you see sporadic LAM. If they don't, what are the things that we look for? So we look for BEGFD, and I'm going to talk more about this, greater than 800, a CT abdomen and pelvis, because if you have a typical chest CT and a renal AML, that's it. You meet criteria for LAM, you don't need any other invasive testing. Or if you have an effusion or a big lymph node conglomerate, you can sample that, and that can also give you the diagnosis of LAM. Now, if you don't have any of that, then at that point you have to consider a biopsy if you want to definitively prove it. But I'm going to talk a little bit more about biopsy. So BGFD, like I said, the LAM cells actually secrete BGFD, and that's believed to recruit lymphatic endothelial cells. And when this was validated as a biomarker for LAM, they explored different cutoffs, and they selected that 800 because 800 is where they got 100% specificity. So it's not as sensitive, it's only about 70%. But their goal with selecting the biomarker was, if we're going to diagnose you, we want certainty, because that diagnosis is we're gonna put you on a very toxic, like a drug that has a lot of toxicity. We want to be sure that we're treating you correctly, so that's why they selected the higher cutoff. And then it has been explored as a biomarker also for disease progression and response to therapy. So if you have a higher BGFD level, you are more likely to progress. And if you have a higher BGFD level, you're also more likely to respond to therapy. One of the things I want to point out is it happens that people get confused about how to send the BGFD testing. So just so you know, the test is only done at Cincinnati Children's Hospital. You have to be careful not to order a BEGF because that will show up in Epic. So and that has no use for LAM. It's BEGFD. So you place the order in Epic for BEGFD, but you also have to send the Cincinnati Children's Hospital requisition, which is this one, and I can give it to anybody that needs it. So biopsy. So when do you biopsy? So first is like you're gonna biopsy this patient if you need to confirm the diagnosis. Now, what happens a lot now is I get these patients that have the coronary CT and don't have any symptoms, PFTs are normal. So I'm like, I'm not gonna treat you right now. I'm not gonna do, so why am I gonna do an invasive procedure? So if I'm not planning to treat you or if it's not gonna change my management, I don't biopsy these patients. And in that case, we call them like probable LAM, but we don't give them a diagnosis of definite. There is an increased risk of pneumothorax because of the lung cyst. It's been calculated around 5% with like transbronchial biopsies, but again, that may vary with center and operator experience. The diagnostic yield, so with transbronchial biopsy, the yield is not bad, it's about 60%. Transbronchial cryobiopsy has been looked at, but there's still limited data to give us a good percentage of what that diagnostic yield is. And then surgical lung biopsy, of course, is considered the gold standard. So for LAM, so the hallmark pathologic finding is that you see lung cyst and LAM cells, like the typical smooth muscle cells. And the LAM cells are going to have staining for human melanoma black, HMB45, which is this staining. These are the lung cysts. It is not a requirement if they have other features and markers that Rob will be able to tell you and discuss with you about. But this is like a very specific marker, but it doesn't need to be for us to say that they have LAM if they have other features. It will have estrogen, progesterone receptors, and it can also have a smooth muscle markers such as smooth muscle actin. So what is the treatment? So the only approved treatment is sirolimus. So sirolimus was validated in the MILES trial. And what the inclusion criteria were very straightforward. You're an adult, you have a confirmed LAM diagnosis, and your FEV1 is less than 70%. So if you have that, they treated you. And it was an RCT in which they also had like a post-treatment phase, observation phase. And what they saw, they did sirolimus 2 milligrams daily with dose adjustments to target a trough level of 5 to 15. And they saw that patients that got sirolimus, their FEV1 stabilized and even improved compared to people that got placebo. And then the moment that they stopped sirolimus, their FEV1 started declining at the same rate as placebo. There was actually also an improvement in the quality of life scores and in functional capacity on sirolimus. So this was the first, and it's the only yet FDA-approved therapy for LAM. There's also some data for everolimus, which I'm not going to use because it's off-label based on a phase 2 study. So I've only had one patient that I offered to, and like I'm still debating on it, but she's still thinking about it. And so what is my clinic protocols? And one of the things with rare diseases is when I was trying to get expert like guidance on a lot of these things, I asked like 3 or 4 of the biggest centers, and I realized that everybody practices a little bit different. It's like, oh, this is what I do, this is what I do. So this is the protocol that I'm used based on guidance from people in Cincinnati and MUSC. So we start at 1 milligram daily, or can consider starting at 2 if they have really severe disease. And this is based on data, on observational data, a lot of the out of Asia, in which they show that you don't need to do like the targeting levels and going on the higher doses, that the benefit can be seen for the great majority of patients on low dose sirolimus. So now this has helped a lot because it reduces the toxicity. So most patients, is you get 1 milligram of sirolimus. And then we're going to look for a trough levels 2 weeks after starting. And the goal is going to be actually to keep it below 10. And if I have to do a dose change, I'm going to repeat the trough 2 or 3 weeks after. And then for labs, I'm going to do a CBC, CMP, and UA in a lipid panel. Why? Because it can give cytopenia, it can give liver toxicity, it can give proteinuria, and it can give hypercholesterolemia and hypertriglyceridemia. So we get a baseline, and then the CBC and the CMP, I get like 2 weeks, 1 month, and then for the first 3 months monthly, because a lot of the patients will have the side effects very early on with treatment. And then at 3 months, if they've been stable, we can space them out. The lipid panel at baseline at a month, and then I can do like every 3 months. But if I end up starting them on a statin, because they start running into trouble with their lipids, then I send them to cardiology and let cardiology decide the interval, because now somebody else can manage that. So the common side effects are going to be mouth ulcers, which I treat with magic mouthwash. Stomatitis is quite common, but with the lower dose, it's less severe and less frequent. Acne, hyperlipidemia, the increased risk of infection, delayed wound healing, lower extremity edema, and ovarian cysts. So the ovarian cysts are a big thing, because if they start having pelvic pain, I get an ultrasound, a pelvic ultrasound referred into OB. Some patients, it can be bad enough that they get this huge cyst that you have to even consider like stopping therapy. Other things, severe side effects, cytopenias. Pneumonitis is one that we worry about, but there were no cases of pneumonitis in the MILES trial. A lot of the data for pneumonitis actually comes from like Japanese studies. So there is thought that some of the predisposition to pneumonitis might have a genetic background to it. Liver toxicity, and then proteinuria, nephrotic syndrome, which if it's mild, you put the patient on NACE. If it's severe, like to the point of developing nephrotic syndrome, that might be a reason to stop. And things like that is when they think about like, okay, maybe you tolerate everolimus better. Important instructions, what I tell the patients, take it at the same time every day. If you get a fever, hold it and call us. You gotta hold it 1 week before and after surgery. You need to avoid live vaccines. It has not been studied in pregnancy systematically, but there's case reports of patients continuing into pregnancy and doing okay. But in reality, there is not enough certainty that that's a common practice. And then multiple drug interactions, no grapefruit use. So treatment, I told you, so FEV1 less than 70, but there's other treatment indications that are accepted based on expert opinion or observational data. So you have progressive lung function decline. What do we call that? If your FEV1 is dropping like more than 90 mL per year, so 100 or more. If you have refractory chylous effusions, if you have renal AML, if you have recurrent pneumothorax, although the recurrent pneumothorax, a lot of the experts in this area will emphasize that pneumothorax is a mechanical issue, and you gotta try to deal with it mechanically before jumping and saying, I'm gonna put you on sirolimus, because the mechanical management avoids that toxicity of the medication. Or substantial disease burden. So if you have a normal DLCO, air trapping, high cyst burden, you can consider doing it, but that's not validated based on the studies. It's just more like what has been seen, because it's better tolerated now than lower doses. There's actually the mild trial, which is ongoing. It stopped recruiting, but they're following, and their goals. So sirolimus 1 milligram in patients that have an FEV1 greater than 70%, and the follow-up is for 2 years, and then at some point we'll have the data for that. So monitoring, FEV1 is the main lung function parameter to monitor. Decline of 100 mL or more is significant. If the DLCO drops, I think about development of pulmonary hypertension. And then you should not make treatment decisions based on a single data point. What matters is the trend, because there is some variability. And I expect their disease to slow after menopause. And again, this is how we do like monitoring. So spiral, you want a post-bronchodilator spiral, because it removes the variability from the response to bronchodilator that these patients can have. DLCO, you can do it more spaced apart. BGFD has been recommended to consider doing it like yearly, but that approach is not validated. So at least I do it at baseline, and then I think about yearly 6-minute walk test and CT chest. There's no like need for a follow-up CT chest, because like the disease progression correlates with FEV1, not with like amount of lung cysts or volume of lung cysts. Although there is some data looking at that, like AI and automated quantification of lung cyst volume as a marker of progression, that's still not ready for clinical use. Pneumothorax, presenting symptoms in approximately 60% of 30% of patients, but up to 66% for them will develop. Things to know is that I tell the patients, if you get a pneumo, call me, because we gotta talk with a thoracic surgeon when they place a chest tube about definitive treatment, even if this is the first episode, just because the recurrence rate is so high. And then, so for the first episode, like expert opinion is like mechanical pleurodesis is fine. it hasn't been like studied in RCT for chemical pleurosis, but the thought was like, well, if we can get away with it later than the road if they need lung transplant, it gives less problem if they were just a mechanical pleurodesis. Talc is considered a second line pleurectomy for refractory cases, and for people that are very like completely refractory, there's something called a total pleural covering. This is based out of Japan, and they have published excellent data for these cases. But I have one patient that I was trying to find out about it because she needs something more, and there's nobody that has expertise here in the US that they could identify that this is the person that you can send them to here. It's all like Japanese. Again, contraception, just gonna quickly, pregnancy, menopause. So avoid any systemic estrogens, progesterone only on OCPs. Pregnancy is associated with risk of progression and increased pneumothorax, so it requires family planning, close monitoring, and multidisciplinary follow-up. Safety of sirolimus is unclear, and for postmenopausal patients, the topical estrogens are fine because the systemic absorption is very low. And transplant, the 2021 guidelines on lung transplant say if you're already on sirolimus and your FEV1 is less than 30, you have exertional dyspnea class 3 or 4, hypoxemia at rest, pulmonary hypertension, or refractory pneumo, referred into lung transplant evaluation. The survival is way better than the average survival compared to other diagnoses, which is median survival of 14 years compared to 6.4. Part of this is the age of the patients with lung that were getting transplanted. I will say that since sirolimus started, the need for transplant has decreased substantially, and that overall, like transplant for lung represent like less than 1% of like transplant indications compared to all other indications. So then, again, which would be the next step to try to obtain a definitive diagnosis, so BGFD. Now, the BGFD testing is negative. What else could we have done non-invasive to try to confirm the diagnosis in this patient that has the CT chest that's abnormal?
CT abdomen pelvis.
Yeah, exactly. So CT abdomen pelvis. I send for a CT abdomen pelvis. If they have a renal AML, then that makes the diagnosis. So Bird will do it. I'm gonna try to go faster. So it's an autosomal dominant disorder, and it's 3 things: hair follicle tumors, lung cysts, and renal cancer. So you lose, it's a loss of function mutation of the tumor suppressor gene FLCN, and that encodes the protein folliculin, and you can identify it in almost all cases. The estimated prevalence, and again, we talk about prevalence in cystic lung disease, but it's about 1 in 200,000. Cysts are going to develop in more than 80% of patients. The rate of spontaneous pneumothorax varies in the literature. It does not progress to respiratory failure. Patients with Bird's-Hole Duvet are not going to become significantly symptomatic. They're not going to progress to respiratory failure. When they have looked at PFTs, on average, mostly have most normal PFTs or mildly reduced ELCO, but no significant progression. Aside from the pneumo, other things to know about, they can present with pneumothorax without lung cysts, and there's cases of that. So on somebody that has spontaneous pneumo without any lung cysts, it's still Bird's-Hole Duvet in the differential. The extrapulmonary manifestations, so the fibrofolliculomas or trichodiscomas, they are like hair follicle tumors. They're indistinguishable clinically. It's a pathologic differentiation because they look like white or skin color papules, and they usually are around the nose, the face, and the neck. They have an increased risk of lifetime of renal cancer, about 15 to 30%. And higher suspicion should be had if you have somebody that has early onset kidney cancer, multifocal or bilateral. That's a trigger for thinking that this patient has Bird's-Hole Duvet. What does it look like? So it's lower lobe predominant. They tend to be more elliptical. They're variable in size, no other parenchyma abnormality, and they can mildly increase over time. This has been seen in papers that have followed them for years, but they increase a little bit over time, but nothing clinically relevant. Diagnostic criteria have been proposed. Again, there's 3 different diagnostic criteria. This is one of the most used. So you either need 1 major or 2 minor, which is either the FLCN germline mutation, or at least 5 fibrofolliculomas, and at least 1 has histologically confirmed And the minor are like the multiple lung cysts that are typical for BHD, early onset renal cancer or multifocal or bilateral, particularly with this histology, or having a first degree relative with BHD. Biopsy is not part of the diagnostic criteria because it doesn't have a defined role in BHD. There's actually not a specific histologic finding for Birt-Hogg-Dubé. It's just a cyst surrounded by normal lung parenchyma. There's no emphysema, there's nothing around it. This just got published late last year, which are this group in Europe that published a guideline for genetic rare syndromes. And they talk about when to offer genetic testing for BHD. And they say, if you have primary spontaneous pneumothorax, multiple lung cysts, bilateral multifocal CA, early onset, the multiple cutaneous hair follicle tumors, or any combination of these ones in individuals or members of their family. Quick point on FLCM mutation testing. So it needs genetic counseling because it has familial implications also. So you need to know what you're getting into if you're getting this testing. Negative results are uncommon because I showed you that you can identify up to like 96% of cases when they do FLCM testing, but it doesn't completely rule it out. And the first degree relatives of patients with proven BHD should be offered genetic testing because it's autosomal dominant, so you have like a 50% chance of having inherited the mutation. At Yale, normally if I want to do it, is I send them to the Smile Cancer Genetics. I do a referral to them. They'll do the counseling and then they'll do the testing. The management, there's no role for monitoring PFTs or any imaging. Our sole role is dealing with pneumothorax if it ever happens. The main things I told you need to establish care with a urologist because it's the recommendations starting at age 20, they need imaging and prefers an MRI with IV contrast, an abdominal MRI with IV contrast every 1 to 2 years. Lymphoid interstitial pneumonia is a lymphoproliferative in the spectrum of lymphoproliferative disorders. Where I see it the most is associated with Sjogren's or HIV. But there's other associations, other connective tissue diseases, RA, lupus. It can be seen with immunodeficiencies like CVID, and associated with other autoimmune diseases or Castleman's. What is the radiologic pattern in LIP? They're diffuse, they're variable, they're perivascular. So then you have blood vessels in the edges of the cyst, and they can be associated with ground glass and interlobular septal thickening. Okay. So a definitive diagnosis requires a biopsy. I didn't get much into the hallmarks of the biopsy characteristics. If you read every paper, there's like a standard biopsy characteristic that should be done by LIP. And I remember Rob sent us a paper in one of the ILD conference we were talking about. There's actually some evidence from big LIP cohorts of the complete discordance of radiology and pathology, challenges of the nomenclature of ILD. So that's why most of the patients that I have with LIP have been, the diagnosis being made on radiology, and they have like Sjogren's, or they have like immunodeficiency and not biopsy based. There's a lot of them. The treatment depends on the underlying etiology. And there's a need for surveillance imaging because since it's lymphoproliferative disorder, they can actually convert to malignancy. There's a 5% risk. There's no guideline about how frequently to image. Expert opinion is at least every 3 to 5 years. And here we see a case of LIP that has cystic lung lesions and developed this, which is actually a mucosal-associated lymphoid tissue lymphoma, multiple lymphoma. Langerhans. So Langerhans is a disease that's characterized by the infiltration and destruction of the distal bronchioles by these Langerhans-like cells that are CD1A positive. It's considered an inflammatory myeloneoplasm and can occur just in the lungs or can be systemic. It is near universally associated with smoking when it's PLCH. Although there are more cases in the literature of like marijuana and vaping. So I told my patient, no smoke of any kind. The pathogenesis is there's somatic mutations in the MAPK pathway, mitogen-associated protein kinase pathway. So how do they look? So they're upper lobe predominant, they're regular bizarre-shaped cysts, they're paramediastinal, in subpleural distribution. Their size varies a lot, And the cystic lesions usually start as centrilobar nodules. So this is a patient that this is how it look at the beginning, and this is how it looks 7 years later. How does it present? So cough and dyspnea in active smokers or marijuana users. Spontaneous pneumothorax happen about 50 to 20% of the time. Signs of pulmonary hypertension because it's associated with it in the severe cases. And one of the things to emphasize is look for symptoms of systemic LCH because you don't assume somebody's PLCH and miss a symptom. So things that I usually think about is any bone pain, any like pathologic fractures, think about lytic bone lesions. And so a bone survey should say bone pain. A bone survey, there should be a low threshold to do a bone survey. Diabetes insipidus, so sodium, serum, and urinosum. Focal neurologic deficits, MRI brain, abnormal LFTs because it can give liver involvement, cytopenias because it can give bone marrow involvement. So here's a lytic lesion of the skull, and here's a lesion in the pituitary gland on an MRI. There's actually guidelines from the heme perspective. There's guidelines for the management of systemic LCH, and it also covers a lot of the pulmonary manifestations. But the reality is, if I'm thinking somebody has systemic LCH, I'm already referring them to hematology. Here is Alfred Lee, who's sort of like our expert in LCH. So diagnosis, imaging, based diagnosis. So you can give a fairly confident diagnosis of PLCH on somebody that's a smoker, that their CAT scan looks typical, and that they have no signs of systemic LCH. Now, what is the yield of the biopsy? So transbronchial is less than, for example, for LAM, this is just like 30%. Cryo, it's about 80 on limited literature that is available. Surgical lung biopsy is the gold standard. For the boards, you can also make the diagnosis in a BAL that shows more than 5% CD1A cells. Now, the validate, like doing the testing and the standardization of the testing is complicated. So I actually haven't done one, I haven't done one myself just because there's caveats to that. Now, if you get a biopsy, one of the things that they emphasize is to request that BRAF B600E mutation testing and also test for all other MAPK mutation testing on the tissue sample because it's gonna have to do with treatment decisions. So what is the treatment? So 2/3 of patients are gonna get better, just tell them to stop smoking and they're gonna get better. But no marijuana, no smoking, no vaping. Steroids have been tried and there's limited evidence. Now, targeted therapy with MAPK pathway mutations, for example, bumrafenib, there's more and more cases of people responding to this for refractory disease. So what's believed is that normally this is the MPAK pathway, and normally it's associated, is activated, there's downstream phosphorylation because of growth factors attaching to a tyrosine kinase receptor. But in the PLCH, you have a mutation that actually causes downstream hyperactivation of the pathway, which leads to all the changes that we see in PLCH. So medications that block this pathway are effective treatments for PLCH. And then lung transplantation for end-stage disease. So just a recap. This is the most common condition. So how does it look? So LIP, there's some ground glass, perivascular variable size, Birdhoff Duvet, a little bit more elliptical, paramediastinal, lower lobe predominant, LAM, diffuse, round cyst, and then PLCH is bizarre looking cyst with some pulmonary nodules. So how accurate can we be to diagnose these conditions just based on HRCT? So this is another paper from Cincinnati, where they looked at expert radiologists, expert pulmonologists, general pulmonologists, and pulmonary fellows. And in general, for LAM, the expert radiologists were around 90%, but also the expert pulmonologists and that were about close to 90%. And even the other groups were close, it wasn't bad. And then what they call confident LAM cases is not only that they looked at the case and they said it's LAM, it's no, I'm confident that this is LAM. And what's even better, so even close to 100%. Now for non-LAM cases, that was different. So for non-LAM cases, about 70% for the expert radiologists and close to 80% when they were confident with the diagnosis, and then it steadily drops on the other groups. Now, if you look at the expert radiology diagnostic accuracy, just based on overall diagnosis, so overall was 80% on all cases. Now, if they told you they felt confident about it, overall was 90%. Look at the numbers for LAM. If they tell you they feel confident, it's 98%. PLCH, 100%. BHD, 89, and then LAP is the most difficult one. But that's why when I review a CAT scan with thoracic radiology and they look at it and like Amy tells us, no, this is LAM. I feel pretty confident about that. And laboratory evaluation, there's no standard approach. Initial testing I consider. So for LAM, I always send the serum BGFD, LIP, ANA, SSA for Sjogren, HIV. Other testing is testing for rheumatoid, immunoglobulin levels, testing for paraproteinemias because they're associated with like amyloid, which is another cystic lung disease, and you can see paraproteinemias in LIP. EBV and HDOB shows up in like some papers for LIP. I've never like really sent this. Now the referral to genetics for FLCN mutation testing, just from a resource utilization standpoint, I first do the serologist, and if the serologist don't give me the answer, then I go back and tell them, okay, we're going to send you to genetics because I don't want to be sending people to genetics off the bat when I can try to diagnose it with like the CT abdomen and the serologist first. So bronchoscopy and biopsy, we talked about that. There's a role for tissue sampling. It varies depending on the condition. PLCH, the one that can diagnose BAL, LAM, PLCH, with transbronchial, surgical is the gold standard for all of them. And cryobiopsy, we need more data. And always tell patients there is some increased risk of pneumothorax more than the average patient. Just a way to think about it from an algorithm standpoint. So how do you think about it? So the question is this a diffuse cystic lung disease? Are cysts the predominant features? Yes. So if not, then something else. If it's upper low predominant, PLCH, bizarre, irregular, cyst, and a smoker. Lower low, BHD, elliptical, renal, neoplasms, sarcoplasma, and diffuse. LAM, female pneumothorax, AMLs, diffuse LIP, perivascular, cyst, ground glass, Sjogren's, HIV, and then amyloid, which is cyst with mural calcification, lung nodules, multi-organ involvement. So, for example, this one, anybody want to venture a guess of which, based on that algorithm, what would you call it? Looks, there's some ground glass, blood vessel here. Anybody want to say? LIP. Yeah, LIP. Okay, looking at the algorithm again. Anybody want to venture a guess in this one? Like from top to bottom? I don't see much of the bases, more of the what? Yeah, PLCH. Again, this one a little bit more interesting. There's cysts everywhere, the variable in size. I put this for a reason. Long nodules, scan. These are all like images of my patients, my cases. Cystic nodular amyloidosis. Okay. So just finish. So undiagnosed diffuse cystic lung disease is actually a diagnosis that we have to face. We won't be able to identify a diagnosis in every case. It's becoming more frequent now that everybody's getting a CT for different reasons, because if we find a few cysts on somebody that's asymptomatic, once we do the serologies and the non-invasive work with their negative, I'm not going to biopsy them. The recommendations to do observation, PFT monitoring like every 6 to 12 months, particularly if they're asymptomatic, if they have normal stable PFTs, low cyst burden, postmenopausal, low concern for malignancy or infection. General recommendations, tell them to avoid smoking, stay up to date in their vaccines. There's no recommendations with flying as long as they don't actually jump from the plane, so they can't skydive. So no skydiving, no bungee jumping, if anything that's gonna that increase the risk of pneumothorax in the extreme. Avoid flying for 2 weeks after spontaneous pneumothorax. The BDS statement recommends 7 days after resolution in chest X-ray. If they ever have sudden chest pain or shortness of breath, seek immediate medical attention. And then definitive management with fluorodesis following the first episode. So, like I said, we're a Lung Foundation clinic since January 2023. We're the only one in Connecticut. And so far I've seen 60 referrals approximately. I think I'm missing a few because before we started like collecting the data. But just for a frame of reference, like there was a recent study out of one of the biggest centers that they published their data for 23 years, and their cohort was 450 patients. So I think 60 patients in 2 years is not a bad number, and we're growing. Now we're getting more, at least a couple of referrals every month. So diffuse cystic lung diseases are a heterogeneous group of disorders that vary in their presentation, pathogenesis, treatment. It's important to differentiate cyst mimics and to know that a meaningful number of cysts must be at least 5. Expert radiology review can make the diagnosis just based on their impression. You need to know the extrapulmonary manifestation so you know what to ask and what to look for. And not all patients by the end are gonna have a diagnosis, and you just need to know how to reassure them. And then this Yale ILD Center. Danielle, with kind words, she's the director, all the people that I have the pleasure of working with. Part of the becoming a Lung Foundation clinic was to prove to them that we would have like a wide network of collaborators to offer them genetics, reproductive endocrinology, interventional radiology, thoracic surgery, pathology. So this is part of the process that we submitted. Now that we're a Lung Foundation clinic, I go to the quarterly national clinic, like the clinic directors meeting, and we all like meet every 3 months and discuss cases, get updates on the clinical trials. We're part of the national rare lung disease consortium. So we see like I get help and like expertise, for example, for other rare lung diseases with this group. So it's been great. Like the Lung Foundation's like an excellent organization. I really want to thank them for their support also. So. And I also want to thank my colleagues who have been, Danielle, Murdu, who have been extremely supportive of me taking on this endeavor.
Is this on? Yes. That was a terrific talk, and I'd like to open it up for questions. Rob Homer, let me just come across so that people online can hear you.
I can say a lot of things, which I won't, but the only thing I'll just say, I'm pleased that Land is easily diagnosed by radiology, but the one other test you didn't mention was that it is actually possible to do mutation analysis for TSC1 and 2 on the tissue. And HIV45 is actually pretty insensitive on a small biopsy, and it's possible to do that testing, which increases sensitivity. It's not 100%, but that's sort of another thing to, if you're really pushing it to the wall, that's another thing to do.
Yeah, so the TSC mutation, interestingly, is not recommended as standard part of the workup, but the FL, but they
on the tissue, on the peripheral node in the tissue, you can do.
Margaret and Mark.
Anyway, I don't know. I was just thinking as you were talking about this, when you treat with sirolimus, does that reduce or get rid of the cysts? No, because you said one of the side effects is they develop ovarian cysts, and I'm like, is the mechanism of the cyst development the same? Does anybody know?
No. So actually, that is a very good question. I don't think it's completely clear, like the mechanism of the cyst development, but they doesn't like affect the cyst in the lung the same way.
So BHD is one of the genes that is associated with ciliary movement. It's interesting that it's also associated with the follicular gene. It also has a tumor suppressor function. So that may be why that's.
Thank you. I was going to say 60 referrals is not shabby at all, given the fact that I think you said there are only 70+ patients in the state of Connecticut that probably have LAM. Obviously, those are. I was also going to comment, I feel really stupid after your quiz, given the high data of being able to diagnose these things. So I think another answer on your multiple choice question should be F, refer to JP as another option. My question was related to LAM. How long do you continue the sirolimus? Is it lifelong, given the fact that some of these folks don't even need lung transplant after all?
So I didn't get into it because I didn't want to make the LAM part so long that we went over the hour, but there's actually data, 5-year follow-up in sustained benefit and tolerating well. So for now, we assume it's lifelong because patients lose the benefit the moment they stop it. And now that we're doing lower doses, they tend to tolerate it well. So at least we have cohorts following them for 5 years and they're doing okay.
And do you ever use any, in maybe some of the older women in the cohort, do you use anti-estrogen, anti-hormonal therapy as well as adjunctive therapy?
Yeah, that was tested and it didn't show a consistent benefit, so it fell out of favor. But they used Lupron and gonadotropin antagonists before. One of the things that were a couple of case reports, for example, were oophorectomy for treatment of LAM in the 70s and things like that. And there were patients that improved and their disease stabilized after oophorectomy, for example.
Thanks, JP, for a really wonderful talk. It's always great to get updated on this, and we do see these cases once in a while, and it's just have to dig back into our memory bank and then get updated at the same time is really helpful. My question relates to LAM also and the sirolimus, sort of two-part question. Some of these folks end up in the COPD program clinic because they have airflow obstruction and someone has interpreted their cysts as being emphysema. It's tricky if they've also been a heavy tobacco smoker and they have airflow obstruction, as to sort of which is which and what to do about the sirolimus. My question really is, do you have a general cutoff with the LAM patients as to what severity of airflow obstruction they present with as to whether it's worthwhile starting the sirolimus? Like, for example, if they already have really severe diffuse disease and very severely impaired lung function already by the time you see them.
Yeah, so there is no cutoff. There's a benefit even in more severe patients. That being said, the only thing that maybe I would consider, there is data about because of the sirolimus in wound healing, there's all this debate about what to do with the sirolimus in the peri-transplant period, the patients that are going to get transplanted soon, about whether it's worth, if they're going to be called any minute now that they found the lung for them. And ideally, we want a washout period of the sirolimus. There was even some experts recommend, no, those patients should be switched over to everolimus, which has less an effect of wound healing. So that will be the only time I'll say I'm not going to offer you sirolimus. The good thing is we're seeing less cases of those so severe that you're even thinking those questions.
Hey, JP, that was great. Thank you so much. You outlined a relationship between estrogen and LAM that I think it's really interesting to think about catamenial presentations, so cyclical manifestations of this. And I was wondering if you see that at all in young patients and premenopausal patients. Do you educate them about expecting symptoms that happen?
Yes.
Do they have an emergency plan for a particular part of the cycle?
The big things, because estrogen plays a key role, the big things against the contraceptives, pregnancy is a big discussion, whether they're going to get pregnant or not. And then there's actually, it's very well known that there's variability of symptoms across their menstrual cycle. And there's a ongoing study, which is observational, collecting data in which women get this diary and enroll and document their symptoms across their menstrual cycle just to have a better understanding. But the patients with LAM get told you might be more symptomatic or you might feel some sharp chest pains here and there according to your menstrual cycle. That's just part of your disease, but that sirolimus helps with that. It's just more education. But yes, periods of high estrogen can make them have spontaneous pneumothorax and worsening symptoms.
I'm just gonna wrap up with a couple comments, and one question from, the Zoom. So Kathleen says, that's amazing work, JP. I did not realize all that you've done for the LAM community and other cystic lung diseases. Congratulations, outstanding. And Richard asks, what is the rationale behind the use of sirolimus treatment?
Oh, because because sirolimus actually acts on the mTOR pathway, so it's blocking that in the mammalian target rapamycin, which is actually the main like hyperactivation mechanism in the lung cell. So that's how it was. Like a lot of the groundwork for that was like actually Lisa Hensky and like out of Brigham, and yeah, that's why other medications such as everolimus and other targets that are being explored are all in that pathway.
Great. Well, I think we'll wrap it up there. That was a really terrific talk and we really appreciate it.